good difference. Now I'm going to talk about autosomal dominant polycystic kidney and autosomal recessive polycystic kidney in very brief. Okay, so first of all, let me share my screen. So let me share my this thing. So I will draw something for your benefit. Okay. Suppose if you have gone through my renal embryology video, you would have remember that from at around the 5th week of gestation, there is something called the mesonephros getting developed. Okay, mesonephros getting developed. Okay, mesonephros getting developed. Okay, it sends a mesonephric duct. The mesonephric duct goes and opens up in what is known as the cloaca. Now, at around later, so this mesonephros actually goes off. It doesn't exist. And in fact, the definitive kidney is formed by the metanephros or the metanephric blastema. It is formed in the pelvis. It's formed in the thoracolumbar segment. It's formed in the pelvis. It's later, it's around 7 to 8 weeks. What really happens is there is a bud, ureteric bud development from the distal end of the mesonephric duct. So this goes and interacts with this metanephric or metanephros, or what is known as the metanephric blastema. This is the ureteric bud. So if we will draw the picture like this, let me show you. This is the ureteric bud. It branches. So ultimately, what happens is this part is known as the ureteric bud. This part is known as ureteric stalk. And this is a branching from the ureteric or the metanephric, the mesonephric duct, right? Now, what really happens over time is the metanephric blastema or the metanephros forms what is known as the metanephric cap. It's known as a metanephric cap atop every budding of the ureter. Okay, so ultimately, with time, what really happens is, suppose this thing becomes an S-shaped structure. So this should form the S-shaped structure. This is what is known as the collecting system of the kidney. Kidney will have two parts, right? One is the collecting system. So what is the collecting system? We know when you draw the kidney, it looks like there is the minor calyx, major calyces, pelvis, ureter, and it drains out. And the end part of this minor calyxes is basically the collecting ducts. So what this is actually determines is the collecting duct. Now, so suppose this is the collecting portion of the kidney, which is a part of the ureteric bud, which we can say is a collecting duct, while this metanephric blastema, the metanephric cap or the metanephric vesicle forms the excretory system. So what really happens, there is some reciprocal, what is known as a reciprocal interaction. There's some growth factors being secreted from the metanephric blastema, some growth factor being secreted from the ureteric bud. The act on itself is called the reciprocal induction, and ultimately there is a connection between these two. Okay, between these two. But due to any reason, if there is no connection between these two, what really happens is the excretory system, or what we know as the metanephric vesicle, it enlarges and forms a cystic space. So ultimately it becomes what is known as the polycystic kidneys. Okay, so what really happens is the one part. So it will happen in all the nephrons. So there are 2 million nephrons. Okay, so all the nephrons in every part, randomly, there will be the cystic dilatation. So what is really the implications of this? You can understand now. You can understand that ultimately what really happens is let me draw again, is the whole kidney becomes studded with cyst. Now, there are two forms of polycystic kidney. One is the adult type polycystic kidney. Both are basically genetic, by genetic mutations happens. One is the adult type polycystic kidney, which happens basically in adulthood. And there are many people, affected patients, who will be harboring the cysts, okay, but they will have clinical manifestation at 40 years or before, 40 years or later. The other is known as the autosomal recessive polycystic kidney, which is basically the infantile form and which affects the babies or even before birth. The patients can die due to renal failure very early. What happens in adult dependent, the autosomal dominant polycystic kidney or the adult variety of the polycystic kidney is there is mutation in two genes. The ADPKD1 gene, which is I think it's 16 chromosome, ADPKD2 gene is 4 chromosome, while this ARPKD, that is the ADPKD, that's known as the the adult recessive polycystic gene HD, I think PKHD gene, which is present in 6p12 locus. Okay, so what really happens in the polycystic, the ADPKD1 gene, the one gene which is more, having a worse prognosis than the ADPKD2 gene. This basically produces some proteins, codes for proteins, known as the polycystin 1 and the polycystin 2. What does they do? The function of these proteins is basically, let me tell you, it's basically it's basically is there's a luminal membrane. Everything is a luminal. Even you see the vesicles, they're basically luminal structures and they have a membrane. Okay, epithelial membrane, and over there are cilia. Okay, these are cilia cells. Okay, or most of the epithelium in our body will have cilia cells. It's basically on the apical portions. Now these polycystin will be a part of this ciliary elements. Well, what really happens is with time they code for some calcium channels, so they will help in calcium influx and will prevent water influx to aquaporin genes. Now the second, aquaporin channels, and the second thing is that it prevents excessive formation of this ciliary component and the cilium and the epithelial component. So ultimately, if there is any obstruction in the function of the genes, there will be lots of there will multiplication of this tubular epithelium. Okay, so what really happens in the ADPKD is that the person will have two genes. Okay, we have always have two alleles. All these persons will have an abnormal PKD1, PKD2 genes in one of the allele, but the other allele they don't have cyst because the other allele is fine. This is the wild type of gene, the normal PKD1, PKD2. But whenever there's a random mutation, so what happens is this allele becomes non-functional. So ultimately, PKD1, PKD genes becomes non-functional. Ultimately, the cilia, the work on the cilium cells becomes inhibited. The calcium influx becomes inhibited. Extra aquaporin channels are introduced. So there's a lot of water inside. And as I say, the tubal epithelial cells will proliferate. So ultimately, they will have a lot of cystic spaces, a lot of, large cystic spaces filled with water from the cysts. And what does cysts do? They compress upon the rest part. So what really happens is, I can tell you, let me draw the diagram. I think that's important that you understand by seeing the diagrams. Very important. So if you have any question, ask me while I erase, because erasing takes time on this Google board. Okay. Let me show you. So, right. So what really happens is, suppose this is a, as you said, a nephron. Moment's capsule, proximal conveyor tubule, the loop of the Henle, distal conveyor tubule. This is the cortical part, so this is the medullary part. And the tubular epithelium form a cyst over here, and the medullary part also exists over here. This compresses on the rest of the normal renal parenchyma. What really happened? There will be obstruction to the blood flow because of the ischemic damage or the effect of the volume effect of the cyst. So ultimately, as we know, this is the afferent arteriole, efferent arteriole, blood flow goes, there's a macula densa cells, the juxtaglomerular apparatus, release of renin, angiotensin aldosterone system, and there's an increase in PP. Because of obstruction, there will be obstruction of flow of urine, there will be formation of stools. Okay, and then there can be bleeding, and ultimately this polycystin genes also codes for ciliary, the cilium cells in the liver. They will have some liver problems. In the heart, they will have aortic root dilatation. In the brain, perianeurysm ruptures. and multiple other things, pancreas and seminal vesicle cyst. Also in females, they will have a, because these are become estrogen dependent also. So they have a large liver cyst. We can often rupture when you give an HRCT or estrogen from external. So OCTs, if you give the contraceptive pills can cause also this liver ruptures. It's very important. Okay. Now, what this is all about? So, you can understand. Ultimately, the patient will land up into ESRD, that is the end-stage renal disease, with time, and ultimately they will require long-term dialysis and renal transplantation. So, they begin with hypertension. So, the treatment is focused at the symptomatic presentation. If there is hypertension, controlled hypertension, ACE inhibitor, because it is renin-angiotensin system mediated. You can do AC, also the angiotensin receptor blockers. For failure, obviously you have to go for all these treatments. Cyst, if you have the pain, bleeding, you can do local treatments. Okay. What actually happens in autosomal recessive polycystic kidney, the same thing happens. It codes the PKHD1 gene codes for fibrocystin, which has the same relation and action on these tubular ciliary proteins on the cells. So it happens is that it's autosomal recessive. It often occurs before birth. So if the urine production is decreased because of renal failure, the less amount of amniotic fluid, obviously the patient will be having less amount of lung development because of oligohydramnios. Because of the oligohydramnios, the ureter wall will compress upon the baby, and the baby will have a compressed nose and the club feet on the portal faces. And about most of these patients do die from renal failure and from lung hyperplasia. Again, treatment, there's no much treatment of ARCT. Okay. So, that's it. That's what I wanted to say about the polycystic kidneys. And if you have any question, you can also send me a question in the chat box. But do please see this in conjunction with my renal embryology video. The link I will be sending along. Okay. So till then, till I come back, stay healthy, stay fit, and keep learning. Bye bye.